there was a bipartisan group of senators, excuse me, that sent a request to CMS asking them about maintaining telehealth and if non-HIPAA related solutions can be used. So right now with COVID, the HIPAA regulations were relaxed about the tools that you can use to use telehealth. So previously you wouldn't be able to use anything like FaceTime, Facebook Messenger, Google Hangouts, different kinds of tools like those. So the senators also asked for a security report to see what the risk would be to keep things where they are now. So you can use tools that might be more user-friendly for people. That is, oh, I'm sorry, I missed one other thing. The other thing that we are continuing to do is look at the numbers, not only in our state, but around the country as reopening is happening. And so we continue to monitor that, and we haven't had any significant decisions made at this point, but we just keep making sure that we're taking a look at things and we'll take appropriate action if necessary. That's all I have. Are there any questions?
Doesn't sound like it.
I have.
Oh, wait, I'm sorry. Malkaya. Yeah, Malkaya, go ahead. I'm sorry.
Not clicking fast enough. Diana, I was just wondering, has there been any changes on the tablet situation, that the tablets we purchased for people we serve, if any of those have been dispersed?
That's a great question. And what we just need to do is we've got the request in and we need to finish that formula to get those out into the hands of people served.
Okay.
I will make sure that we do an update when those have been dispersed.
Okay, thank you.
You are welcome.
Jonathan, you have a question?
Yes. Diana, is there an ECD or an estimated time of completion for that when they're going to go out? Because we've been hearing this preparation for it for a good month or so.
Yep, you are absolutely right. It's on me. And so I will be working in the next week or two. And it's just more, there has to be a formula, because what we're wanting to make sure is that that is dispersed evenly. So I would say beginning of August, mid-August, we'll have those out.
What is the formula, if I can ask?
Yeah, so we're just going to do a percentage, but what we have to do is back out people who are in specialized residential homes. That's what's made it a little bit trickier, is because if someone is in specialized residential, we have allowed for the provider to get reimbursed. So if we just do the calculations on people served, the calculations would be off.
Are there any other questions for Diana?
Just one. Are you running the requests coming from individuals, or are they coming from core agencies?
That's a great question, Malkaya. They are coming from the core agencies, and what we will do is get the tablets to our providers, and then they will get them into the hands of people served.
So is it like a certain number per provider? Because some providers have more people served than others. So is it you know what I'm trying to say? Are you going number of people that the providers? Okay, thank you.
Yep, you actually got it spot on, Malkaya. I knew what you were saying.
That's amazing, because I'm happy today. Thank you.
You are welcome.
Any other questions for Diana? Doesn't look like it, Diana. Thank you for the update.
Thank you.
Anya, you want to give a financial update?
Sure. So I don't have anything major that is different from the last time, other than we did get our June capitation payment, which not only included our proportion of the $2 direct care wage increase, but also, as mentioned a couple of times, did include the continued increase in eligibility trends. So our June capitation was just slightly under 25 million. And it's for those of you who pay attention to this, unfortunately, um, we started the year at about 19 million. So it's a significantly bigger amount. Probably 2.5 million of that is the $2 increase, and the rest of it is really related to not only that rate adjustment, but also the continuation of the eligibility increase. So all going in the way we expected it to. As I'm watching the July eligibility trends, they're continuing to go up. So that's good from a revenue perspective, and we're anxiously awaiting any news on the 21 budget.
Okay, Eric had a question.
Oh, I was reading, did I read right that they're thinking about going to a $3 an hour increase for
So they talked about that for a while, but what I believe is in process currently, and bear with me, this is my first day back from vacation, is rather than adjusting to $3, they're extending the $2 increase to the end of September. But the last I heard, that had not been signed by the governor yet. But I know it was mentioned last week by the department at the PIHP CEO meeting. So I'm making the assumption that it is going to get signed or has been signed, and I just haven't gotten to that email yet. But instead of $3, it is just intended to be a continuation of the $2 through the remainder of the fiscal year.
Thanks.
Mm-hmm.
Okay, Jonathan, you got a question?
No, thank you. Anya, does this mean that every employee of every core and direct provider is going to or should be seeing a $2 increase in their hourly rate?
No,
or is it just for select employees?
It's not only is it just for direct service provider staff, but it is also a subset of that even that the department identified as, I don't want to say frontline because it's a little more specific than that, people providing services in people's homes. So there was a list of codes that they provided that were the codes that were to be included in that $2 increase.
So the at-risk workers, if you will.
Essentially, yeah. Yep.
Okay. I know, not to use the term combat pay, but
yes.
Thank you.
Mm-hmm.
Does anyone else have questions for Anya? Looks like, hey, Anya, what our difference right now? What are we still about 4 or 5 million under?
I haven't seen the financials yet for May. So to be honest with you, that's what April showed was about 4 or 5 million, but May should be a little better depending on how things played out.
Great. Okay. Don't see any other questions, so we'll move on to Pat. Oh, I'm sorry, Jonathan's back. Jonathan.
Sorry, I do have another question regarding financials. Because we're now looking at May, will it be at this next board meeting that we have a readout by the auditors?
Yep, we are planned for the audit presentation next week.
Okay, thank you. That was it.
Yep.
Anybody else? Well, okay, let's move over to Patrick. Patrick, give us an update on the building update, please.
Okay, just for general information, the build out of the 6,800 square feet space that we approved on last board meeting for ACHC is ahead of schedule. Drywall has been delivered and doors and frames are ordered. So that build out is going well ahead of schedule for the ACHC space that was approved at June 15th board meeting. It's a 15-year lease agreement, and the move-in date is scheduled for October 1st, 2020. Also, I wanted to announce that OCHN is happy to announce a lease has been signed with American Society of Employers. This is a 7.5-year lease agreement, and the move-in date is also scheduled for October 1st, 2020. We followed our procurement process, and we were able to bid out the trades in order to bid for the work, and we were able to save $16,000 on the previous amount projected for the build out. Also, I'll be seeking staff will be seeking approval today for board approval during our July 21st meeting in order to enter a contract for the build out of the space as a capital improvement. We also wanted to give an update on the new broker, which is L. Mason Capitini. I think we submitted documentation that it shared the marketing plan details in your board packet. They're actively working on marketing plans for the remaining 2,200 square feet of the building. So that was the update. Also, the ACHC and the ASE build out are both capital improvements, and those will be added to our capital improvement update as those dollars are added to the capital improvement of the building.
Okay, Jonathan, you have a question?
I just wanted to say something. Patrick, congratulations. Awesome job by you and the team.
Okay, thank you. I was very happy to see this lease get signed. It's been a long time in the works, and we were happy that even during what we're dealing with now, that they were still proceeding with occupying space in our building.
So we only have like 2,200 square feet that's unaccounted for yet, right?
That's correct.
That's great.
I will be presenting the information for the build out for next board meetings approval in order to proceed with the build out of that space. And, the amount that we're seeking build out approval will be $355,000.
That's a lot of money.
Well, I mean, it's capital. It's actually a capital improvement that would stay with the building, and it's once the lease is terminated or they decide to stay on that space, the investment stays with OCHN for the appreciation of the building.
Are you gonna be able to show a break even with some of these or the entire building during the review?
I will be able to provide some analysis, hopefully during the next meeting.
Yeah.
I'll be able to provide, yeah.
The board meeting when we go for approval, I think it'd be helpful to see. I don't know what everybody else thinks, but to me it'd be helpful to see. Okay, when do we break even? If we're signing the 7-year lease and then other lease, let's see. Okay, that's good. You got to put the investment, but where's the break even?
Yes. That we can make sure that that's included with the approval request.
That'd be great. Any other questions for Patrick? Oh, Eric just said, I'm reading Eric's comments here. He'd like to see the break even too.
Okay, we will make sure that we provide something for you when we request for the approval.
Okay. Mm-hmm. Any other questions for Patrick? No? Okay, why don't we hand it over to Christine? You're going to give us an overview of the communications team.
I am. Thank you, Pat. And I want to start by thanking each of you for taking an interest not only in my team, but in all of our teams and understanding our role within this organization. As many of you already know, I report directly to the CEO. However, because of the nature of the deputy executive position, director's position, I also work very closely with Nicole and have been really fortunate during some of these difficult transitions to be able to collaborate with strong leaders in leading us and navigating us through some difficult times. Many of you work with me frequently, but I'm excited to introduce you to my team. I know you hear their names, but being able to highlight and explain their roles within the organization a little better. We are set up about 3 years ago. We made a decision to strategically set ourselves up similar to a public relations firm, whereas our team members act as account reps for different teams within our organization. So for example, Debbie provides communication supports to our office and recipient rights teams. Emily supports substance use disorders and the justice teams. Suzanne supports our provider network team. And then I support our executive team and all other functions, of course, with their support. It's really helpful in their roles to have those innate characteristics which each one of them possess. They have tremendous integrity, they're kind, and really fill their jobs with a lot of sincerity and compassion. And so those are characteristics that I think you just look for people, and I'm so glad that they are a part of our organizations. In a summary, I'm trying to keep some of our lists. So we're gatekeepers of information. And at the end of the day, we do the same thing for every project. We read and we do research so that we can have a good knowledge base while relying on our content experts. We write, we design, we coordinate and plan, distribute and receive information, and we repeat. So if you look at every process, I think part of what, because we are such a small team, we have to be efficient. And so every program, every project that is put before us, we take the same approach, and it helps us become better at our skill, and we learn from our mistakes and then apply those lessons to our next task assigned to us. And if you look at where we sit in the strategic plan, we're somehow woven in on every goal in our annual strategic plan in a supportive role for those teams who are actually charged with implementing the goal. We actually fall under advocacy and empowerment, and our real primary function is to increase awareness about our system, but also to highlight the successes and the achievements of the people within our organization. And I know we have a lot of conversation about, we have a number of people in our community who still don't recognize our name. And so we're always faced with that challenge. One of the things I like to say to our team, because that can be frustrating when they look at all the work, is we are in a unique situation in a community where you don't need us until you need us. And when I say that, there are people with private insurance or people in the community who may be having similar challenges, but if they have private insurance, they're not even really looking to hear or know about a public mental health system. So we make extra efforts to target those communities where we know people would meet criteria, but we also try to connect as much as possible to those communities of people who aren't necessarily looking for public mental health system, but we also want them to be aware of us. And we do that through a number of initiatives, which would include our anti-stigma efforts, community engagement, advocacy, and the advocacy really sits at both local, state, and national levels. Funding, we are funded through administrative dollars, at times grants. As the suicide prevention efforts that we maintained for 5 years was through a grant, and also through PA2 and SUD funding, which is usually very specific to SUD programs and projects. So I broke our overall, while it's much more complicated, if there was anything I wanted you to walk away with, it was the 3 C's in our roles and responsibilities, which include communication, community collaboration, and then crisis management. So I will say that 90% of everything you see, read, or hear about this agency at one point or another filters through our team, either through myself or Suzanne or Emily or Debbie. And we're always trying to help people with language, with ensuring that if we've written something, just because it makes sense to us doesn't mean that it makes sense to everyone. So we're always looking for input. We manage the distribution and production of all of our brochures, our newsletters, any of our media messaging. We work off of an annual plan, and I did include a copy of that in Boardable. Every January, we sit down and we map out what we're going to be working on for the next 12 months. So while many people are in March, we're already planning for June. And when we're in June, we're already planning in September. And it helps us be prepared in case of those unexpected events that we need to step up and address. So we're always ahead of the game in our planning. In terms of board influence, I think that is represented in engagement. There are a number of changes we will make to special events. We have special events, minority mental health being one of them, that started with a suggestion from Malkaya. And then any important messaging that needs to be delivered to the community, we do seek board approval. Flyers, announcements, those types of things are usually shared with the board for more on a FYI basis. Because some of our work, especially with public relations, is not necessarily tangible, we do use a formula to measure our analytics. I know some people are looking at this slide saying, Burke has more than 5 bullet points on this slide, and they're smiling, and I do have more than 5 bullet points on this slide. But I wanted you to have a sense of how and when we're communicating with people. We distribute our newsletters on a quarterly basis. The Stepping Stones is mailed directly to homes of people we serve. Let's Talk is electronic, specifically with our press clippings and news articles. And we share this information with our network. So we monitor, we don't pay for a monitoring system. And now Google has a system in place as such that it's not necessary to do so. These numbers are probably a little conservative, but in essence, what we do is we take the size of an article. Say an article is 10 inches long, 2 columns. So we take that space and we multiply it by the dollar value it would cost us to purchase that space if we were running a traditional advertisement. So that's where we come up with the dollar value to put a tangible return on investment to our work. And then circulation is just based off the circulation of those print, or if it's television or radio media. We have had 15 participated in 15 face-to-face events. We usually have a lot more by now, but COVID has changed. We're pivoting quickly in terms of how we're going to navigate and maintain engagement with the community. When you look at our advertising purchases, most of that money does derive from SUD funding. Billboards is something we've also had conversations about in the past, and when you look at neighboring communities and how they purchase their billboard space, we look at the heat maps that IT has provided, and we understand where the greatest population of people whom we serve or would meet criteria for our services live. And so for us, I-75, that corridor doesn't necessarily travel through those communities of the people we want to reach. So while we will purchase billboards, we usually have them up about every 2 to 3 months. You will not see them as much as on 75, but you will see them within communities like Pontiac or Southfield or Hazel Park. Social media, Debbie manages our social media, and so we are looking to enhance our exposure on social media, especially with COVID-19. So this is just one of the examples of our efforts in terms of how do you reach people who aren't necessarily buying newspapers, who may not have a computer, who may not have a phone. So while it is very important for us to take advantage of all technology available to us, we also recognize the minute you say everyone has one, you have lost someone. So I am always thrilled to get an article in the Detroit News, in the Free Press, or the Oakland Press. But it is equally important from a philosophical perspective for me that we are in those free publications that are delivered right to people's homes or are placed in doctors' offices. So those individuals who may not be searching on a website for news or who may not be buying a print newspaper still receive information that is important to their community. This year was the first time we did something with Spotify. So we're targeting youth, and it was with a substance use campaign. So we are going to be dabbling more into that medium as well. Community collaboration, our work is all about relationships with the people we serve, staff, board, our community partners, our political leaders. I was very fortunate when I joined to have Vicki be my boss, and she took extra time to ensure those first few months I was here that I really was put in situations and positions that I understood the value and importance of having strong relationships with the people we serve. And this is absolutely necessary to establish that credibility and trust so that if they have concerns, they feel comfortable in coming to talk to us. If we're not hitting the mark, if they're not getting the information, I think that level of respect then allows us to be responsive to their needs. In terms of when it's ongoing, every day we plan something in a manner of who are we going to communicate, how are we going to reach them, a work group, special events. All of those things are just ingrained into our annual plan. And even though it's coordinated by the communications team, it's really supported by the entire staff at OCHN. I think later in this report, I do have some numbers that I'll highlight more, but we monitor very closely where we sit at the table, who's sitting there, how long we've been there, and are we speaking up? Are we talking about those issues that are important to the people we serve? And of course, the board's involvement in any of these events and in influencing our relationships with the community are absolutely essential to them being successful. This is just a list, the next two slides, of events that we actually host. So we do stay involved with and attend our community partners events, but we actually ourselves host at least 1 to 2 a month. Right now we're doing everything virtually. Tomorrow is our first big test for our first virtual forum, which will be Minority Mental Health Month. We did a run through this afternoon, and I think we're all pretty excited about it. We've tried to put in some new elements to make it more interactive, to hopefully be more engaging. And then of course I mentioned the Lieutenant Governor has agreed to speak, which was very exciting for my team and really for the whole organization. This is just another list of events that we actually host or are a lead supporter of. And Walk a Mile in My Shoes takes place at Lansing, but when you and if you've ever attended, you will see that almost all of the volunteers that are there working the booths and walking with people and talking with people are actually from OCHN. So we've always had a very strong presence in ensuring that that rally is a success. The last of the 3 C's is crisis management. I will say we've talked about crisis management before. We do have a network plan. I also included a copy of that in Boardable under communications documents. That was developed with input from all of our provider networks. I think the initial thought, and frequently, and unfortunately, when we have a crisis, beyond unexpected events like COVID, it may include the loss of an individual's life in a variety of situations. And what we wanted to ensure is that people understood about HIPAA, that there was a chain of communication of whom should be contacted, when they should be contacted, what information should be shared. I think what we've discovered over the years, though, the most important element that's come out of this crisis communication plan, which we did not discuss, but was a really nice outcome, is that it gave us a platform to support people who were most impacted by that loss. And that may include a case manager. It may include one of our provider CEOs, but it really opened those lines of communication for those people who felt that loss and felt that pain to be able to talk to a supportive peer and friend within our network. Person served impact. I love this photo. When we started doing the recovery celebration, it used to sit with health divisions when Christina, Nicholas, and I first met, and there would be about 25 or 40 people. And when SUD came under our purview, she and I sat down and said, how do you make this bigger? How do you engage and bring people in? We came up with some ideas, and we always have more than 300 people at this event. And what's the most exciting, and I think if you're looking at this picture, a lot of those people that you're seeing in this picture, it's why I chose this picture, they're our staff members, and they are surrounded by people we support who are in recovery. And as far as that impact goes, it creates a connection in the work we do within our organization with the people that we serve. Knowledge is power. When we talk about distribution of information, we always try to get the facts in the hands of the people we serve and then let them form their own opinions. And then from those opinions, we take their lead on advocacy. There are times when there will be a huge advocacy issue brewing, and sometimes people will think I'm being a little quiet for those few days. And what I say to them, and even as an agency, is it's not my role really to tell people what they should advocate for, but to let them tell us what's important, and then for us to assume our role to help them draft their message and deliver their message. So we always try to take that lead. Through those efforts, we promote engagement and inclusion, and we really want to create that safe platform and space so that people can share their lived experiences and values and views. Network impact, we work very closely with our provider PR folks. We meet quarterly, but we're on the phone together all the time. Very early on, we recognized that we were stronger together. Each of us brings a different skill set or strength that maybe the other one doesn't have. And so when we partner those, especially in conversations about advocacy, we have a greater impact in delivering whatever that message, whatever that information is to the community. This was especially important when we were talking about privatization. It's especially important when we're talking about direct support professionals. I think each of them feels pretty comfortable with picking up the phone and calling anyone on my team to say, hey, I need help. I know I frequently call and ask for their expertise on a certain subject matter based on whatever service it is they are contracted with us to provide. So we have a dynamic PR network within our entire system, and we're very fortunate for that. This number is the one, I just got the revised numbers today. We survey our staff at least once a year to find out where they're sitting on work groups. We do this for a couple reasons. One, to identify, are we missing any gaps in terms of the community or a service or a need in the community? But two, to ensure that the work group position is aligned with the agency, just in case that person gets promoted or they separate from the organization. We never want our place or a seat at the table to be empty. So last year, when we looked at this number, we had a little over 100 different initiatives. We were involved in a little over 100 initiatives. We're up to about 150 now in community initiatives where at least 50 or so employees in our organization are at the table all the time with our community partners, talking about those community matters that are important to all of us. These are just a list. ECHO, which is Energizing Connections for a Healthier Oakland, Healthy Pontiac, Rachel Densmore from the Provider Network oversees our homeless initiatives, law enforcement response with naloxone, school transition, and suicide prevention. From a statewide perspective, we are very connected with our political leaders. They frequently will send us new laws and legislature to ask for our input. They have no problem calling us at 6 a.m. or 7 a.m. in the morning and saying, can you get an expert to Lansing to testify on our behalf on this matter? We're fortunate in that we do have those types of relationships with our Board of Commissioners, with our state legislators, and then with our local representatives, that they feel comfortable to turn to us as content experts in mental health services and substance use, and of course in those for people with intellectual or developmental disabilities, because we have those relationships. And this too is reflective of a collective group in this organization. It's not just one person who sits at that helm, that we're able to offer input and offer our voice and actually influence the way laws are written. There are times some things will come across my desk, and in the past we've looked and said, you put the semicolon in the wrong place. That means the law actually states this. And they've gone back and rewritten it and said, oh shoot, that's true. Or we've said, do you understand this greater impact that will happen, the ripple effect in a community that maybe unintentionally someone did not anticipate? We do sit on the state PR work group, which is led by the association. They host the Walk a Mile rally. We meet bi-monthly, and as a state group discuss those things that are different in our regions, but those commonalities that we work together to resolve. Of course, COVID was one, privatization, direct support professionals. We usually are pretty united in terms of our advocacy conversation, and understand that when you advocate for one region, you really do have to look at the needs of the entire state, so that when we are going to Lansing, we go with one voice and we're not going with conflicting messages that could be confusing to them. And now I'm ready for questions.
Hi, this is, hello?
Go ahead.
Yeah, this is Vijaya. I have a question, Christine. This year with the pandemic, how has that impacted your work? And also, what is the most difficult challenge you have faced during this period?
Well, we did need to pivot pretty quickly to a virtual setting. Thankfully, we had Teams. The other benefit for us is that through our Pearl system, we had already been working in different virtual settings. One thing that we've done specifically are doing different. Spring and summer are a very busy time normally in distributing information at special events. Special events aren't going to happen this summer, so I believe I put in a board update. We're purchasing mailing addresses for those communities based on the heat maps, and we're directly doing direct mailers with information to homes. That's normally something we would do at an event. School related, we do 2 huge direct mailings to our schools in the fall and January. We're in the process right now of updating our email list for school counselors, for school administrators. So those materials that we would normally ask them to put in their lobbies, we're going to be emailing and asking them to distribute the information to their families via email. I think the greatest challenge we had after the initial crisis and ensuring people had PPE was to sit back and evaluate how we were going to ensure people were continuing to get information, keeping in mind little things you don't think about, or we do think about as conversations go. I was speaking with someone from the CAC who pointed out to me that for forums and virtual meetings, They're very important. However, a number of people whom we serve have limited minutes on their phones to do a call-in or aren't comfortable with participating in the online virtual events. So in those instances, we're making sure we email the video out to people, or we're doing reach outs and calls. They'll give us a name of somebody and say, he or she has limited minutes, or he or she isn't comfortable. Can you call and talk? So we're looking at what I would call combining those high-tech avenues to distribute communication with just old school pick up the phone and call and mail to make sure that people have the information they need at their fingertips.
Thank you.
Eric, you got a question?
I just wanted to compliment, must be Debbie on the social media. I repost a lot of the Facebook content that's out there, and I usually get, quite a few likes when people, when I repost it. And it was great to see that you're on, that we're on Spotify. I wondered on Spotify, do you target it by like music genre? How's the targeting going on
Yeah, we target most of our marketing and PR approaches in our messaging to a specific group based on the demographics. So Spotify is targeted more so for younger people, and we were that specific ad and campaign was for people, I think, between 16 and 29, something like that.
Right.
So it was our first try with Spotify. I will say this too, the other ways we have our traditional analytics that we monitor. Of course, in the back end of the website, we monitor upticks in how often people are visiting our website, what pages they're going to. The other action that we've had to take after past experience, we know that when we launch a campaign and billboards are up and we're running a Comcast ad or we're running a radio ad, whatever that launch is, an initiative is at that time, we generally will see an increase in our calls to the access center. I think one of our greatest learning lessons and learning curves when we transitioned in the non-emergency calls to the access center, that campaign in itself went over for several months. Prior to that occurring, I believe the access line was getting anywhere between 50 and 60,000 calls a year. So the anticipation was when that transitioned over the non-emergency, maybe that increase to the emergent would decrease somewhat because we were transitioning. But because of the extra efforts in promoting, what we actually saw was that the emergent calls stayed up and the non-emergents almost matched. So we can't see just in some basic outcomes and information shared with us by teams in our organization how that particular campaign impacted and did we attain whatever our initial goal was.
Have you looked at TikTok? That seems like it's exploding.
I'm sorry, have we what?
Looked at TikTok as a social media, doing like social media. That really seems like it's gaining a lot of popularity with young people.
TikTok is. I was just reading some analytics. So for me, the jury's out a little bit on TikTok based on some of the information that I'm reading in terms of the audience, but also the types of messaging. I know it's growing and it's gaining some attention. I'm not sure if it's necessarily the best platform for our specific industry. But I'm definitely looking at, I was just reading an article about TikTok this weekend and last night. So I'm glad you brought it up. It is on my radar.
I was just interested in what you knew about it. I've only heard that it's getting popular. I don't know like what kind of messaging would be appropriate for it or anything.
So what's interesting about TikTok and its longevity is TikTok actually semi-replaced Vine. Vine was a very similar social media platform. It had the same popularity and then it faded out and was replaced by TikTok. So the risk in some of those social media platforms that are transitional is that you could put a lot of investment in a platform and it may fade. Twitter and Facebook have after the time of test demographically align with us a little better. Instagram, we do have a Pinterest. We work on Pinterest, and LinkedIn is we focus primarily for our stakeholders in that business level. But yeah, TikTok's up there. I am going to watch it, and it is interesting to see its growth, and it's funny. I've seen videos. They're funny.
Now,
Thank
Kyle.
you.
This is John Paul. Can you guys hear
Oh,
me?
John Bell, go ahead. I'm sorry.
Oh, okay. Hey, great presentation. I think one of the things that we've found in this pandemic, and it's how important communication is to our community, and being on a school board and as a parent as well, it's been vital in the schools. And I think probably our communications department is proved to be one of the most important departments within our school district. And based on what you're saying here, it's very, very equally as important here. My question was, you were talking about heat maps. What exactly is a heat map?
So Diana's presented on those before. I think you may have seen them. They designate areas where we can see where a large population of individuals whom we serve, or individuals who might make criteria for receiving our services, where do they reside? And we look at that very specifically, obviously, when you're promoting public mental health services and they are geared toward a certain population of individual based on those who have Medicaid or other criteria. While we want to educate the whole community, we also want to make sure the information is in the hands of those who need it most. So the heat maps that Diana's team and I team have created help us to determine for specific target information where we want to make sure that information is actually getting into the homes. Because again, maybe they're not buying newspapers, or maybe they don't have a computer, or if they have a cell phone, maybe they have limited data that they can use, and they're very conservative with it. So those are those areas where you need to make that extra effort. Similar to when we have events, we do direct mailings to all of our specialized residential settings. And that's a little extra effort in putting in that, stuffing all those envelopes and putting in the postage with returned address on it. But the value and input we get from people, it's always worth it.
Yeah, and my wife uses TikTok quite a bit during the pandemic, so that's growing a lot in popularity. So just to piggyback on that, I think that definitely is something that we look into. But thank you, very good information. Appreciate it.
I see Malkaya's hand up. She's waiting patiently, and I hear a TikTok somewhere.
It's not me. Thank you, Christine. It's not a question, just a comment. I appreciate the communications department so much because of number one, you're very responsive. Whenever I call, you get back to me, and I appreciate the fact that you guys really make it look easy. It's not easy, but you make it look easy. So I just wanted to let you know that I appreciate you. And I appreciate the fact that you're open to conversation, because not everything that I bring to you is a pleasant discussion to have. I'm trying to be delicate, but you don't run from confrontation, and I appreciate that so much, because the image of the organization is so very important, and you are right. You are the gatekeepers, and I do appreciate your work, and I also appreciate your tenacity in how you protect your staff, because you have corrected me on more than one occasion when I've said something out of the way to one of the staff people, not intentionally, but when we get passionate, sometimes we're so bent on what we're thinking that we don't consider how we come across to people sometimes. So I appreciate that. I really do. And I appreciate you and your team. And I just wanted to say that publicly.
Oh,
Thank
thank you,
you.
Malkaya. We appreciate you too. Back at you, all things.
Christine, this is Pat. I got a question or a thought.
Yeah.
Usually a Metro ad council has pro bono advertising that you can do on TV and television. And I've seen Wayne County being on television here a month or two ago, quite a bit. I don't know if they got it free, pro bono advertising from the ad council or they actually purchased it, but I think it's worth looking into because one of the issues I think you brought it up, and I know that Dana's brought it up during interviews and so forth, is the OCHM brand, getting it out there for the whole community, and it's kind of a it's a shotgun shot in the sky, right? When you put an ad on TV, but you cover a lot of people, and so I think it's worth. I know some people I can help you with if you want, or if you already know some people in the ad council, in the Detroit ad council area, which would cover Oakland County. I think it's worth a phone call and a conversation with them.
Yeah, I would welcome that. I do know the PR communications director at Detroit Wayne is a close friend of mine. So when those ads were being purchased, they are rather expensive. Not that they're not worth the purchase, and that's a conversation I've heard, Dana. We can have that. It's a delicate balance at times earlier, especially when programs are being reduced, not necessarily in our county, but when you're advertising and the branding is essential, but then ensuring that on the other side, people who are looking for increases in direct sports direct support professionals don't see that as a why are you spending money there, not here. So I heard Dana talk about that. Am hopeful to have those conversations with her. I do know at the time that Detroit Wayne was making those purchases, we actually sat in on the conversations with them to determine, Macomb sat into, we were looking at a tri-county, the funding required for those ads was definitely out of our budget at the time, and they were also being implemented at a time when we were talking about reducing levels of administration and we're really turning our ship around. I think that we're in a more solid financial environment right now, and so that would definitely would appreciate any contacts you have for me. We do have some in terms of public service announcements and some pro bonos. A lot of times what we have been seeing with television, you will get a pro bono commitment to be on an interview, but that is attached to the contract purchase for the airtime. Kevin Fisher and I from NAMI talk about this some of what we have seen in terms of the expense that purchasing through cable is a better investment for an entity such as ours that is publicly funded. But I'm definitely open to those conversations when Dana gets on and see if she has a different version or vision and what her ideas are.
Yeah, no, that's great, Christine. I guess where I was coming to was I was going right after pro bono. I wasn't looking to pay, and I
I'm
don't.
gonna stand right behind you, Pat. You go get it, and I'll be right alongside of you. I think that's great. Just please, anything you could direct our way would be very much appreciated.
Well, at this point in time, I would think that they would be open to that discussion because of the COVID-19 and the impact on people that we serve and that sort of thing. So, because they do have a certain amount, usually, I haven't dealt with the Detroit Ad Council in a long time, but, they usually have a certain amount of advertising time that they will give to nonprofits on a pro bono basis that they think fits their mission, what they're trying to do. So, and then we can, get an ad agency to, twist their arm and see if we can see if we can get pro bono there too. But I think importantly, if we get the pro bono media time, that's what costs the money.
Yeah, I would very much appreciate any input or contacts you could pass our way for that.
Okay, I'll connect with you tomorrow or sometime soon.
Okay, thanks, Pat.
Any other questions or comments for Christine? Doesn't look like it. Great job, Christine.
Thanks. You guys have a nice night.
Yep, you too. Okay, why don't we move on? Stephanie Wilson for the clinical team update overview.
Hello, thank you. My name is Stephanie Wilson. I'm the Director of Clinical Practice here at OCHN, and I also want to thank everyone for the opportunity to be able to share more about the clinical practice team this evening. So if we move to the next slide, is that? There we go. So here is the OCHN leadership organizational chart. And I report to Dr. Lawson. So I am a member of her team there. And then the next slide shows the clinical practice organizational chart. So this is the clinical practice team. This team has a number of individuals in different areas that I will go over in more detail in some of the next slides, but just to say that this is a really dedicated team of individuals that are really passionate about the work that they do. So it is a lot of fun and exciting to be able to work with this team. So for a department overview for clinical practice, this team is really ensuring the use of evidence-based and best practices, along with person-centered planning, as well as the utilization management and review of all services. So within the clinical practice team, there really sits two teams. There's the utilization management and review team, and that team consists of 17 staff. Among those staff, there is a manager for UM and UR. There's also a utilization management supervisor, and then there are utilization management analysts and utilization review analysts. There are also two positions on the UM and UR team that are specific to the substance use disorder network teams. And so those two positions do utilization management and review tasks for the SUD network exclusively. And then there's also the clinical and integrated health team. So that team has 16 staff. That team consists, there's a clinical supervisor on that team. We also house our nurse case manager positions, are members of that team, our clinical diagnosticians, our clinical analysts, and there are a couple of grant funded positions that are also belong to this team, including a healthcare coordinator. That position is housed at Honor Health, and that individual is able to provide some very brief case management and therapy level services for individuals who wouldn't necessarily qualify for services at OCHN. There is also a grant funded position of the social emotional coordinator, and this is the Race to the Top grant through the state of Michigan. And she is focused on the 0 to 6 population, working with child care providing agencies. So some of the initiatives and responsibilities listed that we have here, and I'll talk more about in some slides as we move through, is integrated care. So this one I will definitely be touching on more, but this would include things such as care coordination, complex case management. I know that Emily Patterson and Dr. Lawson talked about the behavioral health homes that we are working on getting up and implementing for FY21. So that would also fall under integrated care. Clinical reviews are something that I will also touch on more in future slides, but this is a responsibility that sits with the clinical team, as well as audit reporting. So we complete audits on the clinical team that are based on the protocols in the utilization management manual. So we audit, we have a schedule that we follow for each fiscal year. So usually around this time, we're finalizing our schedule for FY21 and looking at what audits we're going to complete among what networks, and then getting a schedule specific when dates and time that those are going to be completed. So looking at where our team sits with our annual and strategic plan goals, looking really at healthcare and wellness is a big piece for the clinical team and a big part of what we work on. Again, that care coordination piece, so we will talk more about that, but with our nurse case managers, that care coordination with the Medicaid health plans in Oakland County. Also the population health management. So we utilize the PROACT and the Care Coordination or CC 360 tools to be able to access some of that physical health and behavioral health data, and also helping with looking at HEDIS measures and how we are measuring those and tracking those. And then also the behavioral health homes, as we had mentioned before, and there will be definitely more to come on those getting implemented in FY21. So looking at annual funding source for the clinical team, we do have a combination of administrative and service positions on the team. So some of the positions that provide a more direct service to individuals would be like our nurse case managers. So they are providing complex case management services to individuals, and I will talk a little bit more about what that looks like in some future slides here. Our clinical diagnosticians, so they are completing assessment for individuals, specifically individuals who may be receiving the autism benefit currently and need reassessment, or individuals who are looking at initiating that benefit. We are funded with Medicaid and grant funding. As I stated, some of the positions do have grant funding associated with those positions. So looking at the clinical team's roles and responsibilities, I'm going to dive into these three areas a little bit more in the upcoming slides. So really going to look more at integrated care and what we are working on there, utilization management and review, and then the oversight of clinical service and the delivery of best practices. So to start with, looking at the integrated care piece, really the what we're looking at of that is that care coordination. So this is the piece where our nurse case managers are working with the Medicaid health plans in Oakland County, and certainly also working with our provider network. Individuals identified maybe with high needs or complex needs related to physical and behavioral health are consulted on and collaborated with these Medicaid health plans during monthly calls. And so we make sure to have the providers at the table too, so that they can be coordinating with those Medicaid health plans regarding these individuals. Also, the nurse case managers are providing that complex case management. So this is for individuals who are currently receiving services already through a provider at OCHN. So they already are set up with services, and they can be then referred for complex case management. And they will continue to receive the services that they are getting with the provider they're working with, while in addition receiving complex case management with one of the nurse case managers who is working on addressing some more of those complex health needs. There is a protocol that we have in place that goes over, how to make a referral and what would qualify someone potentially to be a good candidate for complex case management. So taking all of those into account. And then, as you had heard about, I said from Dr. Lawson and Emily Patterson earlier, the behavioral health home implementation, and doing a lot of work around making sure that we are ready for that to begin on October 1st. We want to make sure that we are looking at all of these areas because we want to be providing that integrated approach for the behavioral and the physical health care. And we also want to make sure that we're collaborating with community members and providers along the way. And so we're doing that through providing the direct support for people. The nurse case managers can do in person. They've been doing over the phone, especially related to COVID, with providing that support, but also making sure to do the collaboration with the providers as well, including the health plans. And so they're doing this on a daily basis. And again, it's really the nurse case managers and our behavioral health home program analyst, and then other team members as needed. The nurse case manager may be working on a case with an individual who has, recently been in an inpatient stay. And so they may do some collaboration with a UR team member. So other team members as needed are certainly involved as well. So for utilization management and review, for this team, really the focus is review of services requested outside of pre-approved benefit plans. So those service requests come through to the utilization management analyst if someone is requesting services above what would be pre-approved already. Audits. So I talked a little bit about they do audits across populations, across networks, based on protocols from our utilization management manual. So all of those protocols have an audit tool that goes with them, and the team is auditing those. And then the clinical analysts are the ones who are taking that raw data from those audits, and they're doing a data analysis of that and then creating a report that they're able to share with OCHN as well as our provider network. This team is also completing continued stay reviews of acute care stays. So looking at those stays where someone is in an inpatient psychiatric center or a partial program, doing continued reviews with those. Also, this team oversees the state facility process. And so that process includes from the very beginning when an application is submitted to the utilization review team through the time of admission. So assisting with the admission and coordinating that through the stay up to their discharge. So these steps are really important because we want to make sure that individuals are receiving the services that are appropriate to meet their needs, and really looking at the amount, scope, and duration that that person needs to make sure they're able to have what they need to meet their goals. And so some of the ways that we make sure we're able to do that is we collaborate with providers, certainly our provider network, but also our hospital network. We do a lot of collaboration there, as well as with the state facilities. So there are 5 state facilities in Michigan, and our utilization review team does a lot of coordination regularly with those state facilities as well. Again, this occurs very regularly, and who is involved is our utilization management analysts, our utilization review analysts, the utilization management supervisor, and then also the manager of utilization management and review. So then that third area that I wanted to talk a little bit about is the oversight of clinical service delivery and best practice. So in this, we're really looking at the oversight of current evidence-based practices, or EBPs. So what is currently being utilized within our network, across the different populations, and how is that going? Implementing any new or existing practices, and working with our providers and wherever that training is coming from to make sure we're coordinating that piece. Also, really looking at making sure we're updating our documents. We make sure that all of the documents in the utilization manual are updated minimally annually. And so the analysts who work on making sure those are updated are also making sure that they are having work groups that include stakeholders to make sure we're getting feedback on any updates or any feedback that they have regarding those. We also go through a review process with those documents where they're presented at several meetings that include internal staff as well as provider and individuals served, to make sure we're getting feedback on those at least on an annual basis. And then completing clinical reviews. So the clinical team completes the clinical reviews, and those requests can come in multiple different ways. One way that we frequently get clinical review requests is through our due process coordinator. So if there is a local appeal or a Medicaid free hearing, we'll often receive a request to do a review of that case and what was going on. We get requests from customer service, the recipient rights team, really any team that may come across something that they feel warrants maybe a little bit of a deeper dive into a review. There's a form we have, they complete that and submit it to our team, and then the clinical analyst will review that, complete their review, and share their findings with the requester. They will also share recommendations and any feedback with the provider that we may come across in doing those reviews, and any follow-up that's needed there. So we want to make sure when we're doing this that there is access to evidence-based practices to help individuals meet their goals. And so that's really important, to be able to have access to those and be able to have practices available to individuals with proven effectiveness that they can have. We do this coordinating with our providers, often coordinating with MDHHS, especially around the evidence-based practices. A lot of those are, the trainings and different things are through the state or fidelity measures. And so working with them on that, coordinating training opportunities as they come up, and doing that in a variety of different ways. So who's involved with those areas? Typically our clinical team, including the clinical analyst and the clinical supervisor. So looking at person-served impact, I think when we're looking as the clinical team, we're really wanting to ensure that there's a high quality of services and supports that are available to an individual. We want to make sure that we are using an integrated approach to the care someone is receiving, and that that's available to individuals that's helping them to reach their goals. That's really our main focus. So for the service network impact, we're promoting daily collaboration with our provider network, with the hospital network, the Medicaid health plans within our community. We are doing coordination with all of those areas on a really regular basis. And then also the clinical team pretty much works with every team at OCHN in one way or another, whether we're making sure that we're being consistent in the communication with some of those partners that I listed above, whether it's involving a clinical review, like I had mentioned, or looking at audit results, or just being involved in whatever way we can do to assist. We are certainly involved with the majority of teams here at OCHN. As far as our community impact, looking, locally here in Oakland County, some of the things that I had listed here was clinical best practice meeting. So this is a meeting that OCHN does host, but we do invite our provider network and hospitals and provider hospital network to come and attend and be able to collaborate during this meeting. The Improving Practice Leadership Team is a meeting that OCHN also hosts with our provider network, and also individuals who receive services participate in that meeting. That's where a lot of the review of some of those protocols and audit tools and all of those things are reviewed, and individuals have a chance for feedback there as well. We do have representation from the clinical team on the Suicide Prevention Task Force of Oakland County. I know Christine had mentioned earlier in her presentation the grant that previously we had related to suicide prevention. The clinical team worked heavily on that and was very involved and still involved with a lot of the suicide prevention efforts. We do have a representative, our Dana Fuller, our utilization review lead analyst, represents our team on the hospital transition work group, which is an Oakland County work group. And then the Great Start Collaborative in Oakland County, we do have one of our grant funded positions, the social emotional coordinator. She is able to sit on that. So we do really have a pretty broad reach as far as being able to participate in community work groups and different collaboratives. And then looking at our system impact statewide, we were really excited that Lauren Joslin, one of our clinical analysts, she was appointed by the governor to the State of Michigan Suicide Prevention Commission. So she is a member of that and sits there and is someone that's been heavily involved in the suicide prevention work. We also have a number of different analysts who participate in statewide evidence-based practice work groups. So sorry for all the acronyms down there, but I wanted to just list a few. So for most of these evidence-based practices, there's also a statewide group linked to those where there is collaboration and discussion around fidelity and implementation. And so we do have representation on all of those work groups. I, myself, and our manager of utilization management and review sit on the statewide mental health parity work group, and so are working on bringing parity to Michigan as far as how we are looking at our acute care services and how we are reviewing those, as well as looking at our outpatient review process. State facility coordination. So I mentioned our utilization review team coordinates heavily with our different state facilities across the state, and they do hold monthly coordination calls and consultations with those set up formally, as well as a lot of informal communication. We do have a representative on the Children's Administrators statewide meeting, and then we also have representation on the statewide locus work group from the clinical team as well. So that brings me to the end of my presentation, but I am happy to answer any questions anyone has.
Judy, that's a question. Judy, did you hear me? Might still be on mute. Judy raised her hand.
Yeah, I saw her hand.
I have a question for you.
Sure.
While we're waiting. The behavioral health homes, I know that Nicole went over that. I can't recall specifically what they do.
So, oh man, there are probably many that could describe this a little better, but what we're looking at doing is partnering with Honor Health as well as our providers. And so looking at being able, the state had reached out to us, and we are working right now on setting up, we had identified some individuals who are currently receiving services with our provider network or with Honor Health. And so there are, similar to some of the services, I would say, that as far as case management and some of those things that our provider agencies are able to provide, but being able to open that up to a larger catchment and being able to maybe provide a more intense or different level of service to some of those individuals. And that's just a very generic response. But it would be us partnering the ones who would be providing the services related to the behavioral health homes would be our provider network and Honor Health.
Thank you.
Okay, Pat, I finally made it back in.
Okay.
I don't know, too many buttons to click. Stephanie, I really appreciated all the information that you shared today. And I was just wondering if the clinical supports have much interaction with people with developmental disabilities.
So I will say that the bulk of our supports are dealing directly with the providers. So I would say we have a lot of coordination with our provider network, those specifically who specialize in intellectual and developmental disabilities such as CLS and MORC. But the clinical analysts themselves and like the utilization management and review, they're not doing a ton of like direct interaction with the individuals. They're doing a lot more interaction with the provider network.
So are you comfortable that should clinical supports be needed at the provider level, that they're available? That's always been kind of a challenge in the past.
As far as, I'm sorry, let me make sure I'm understanding your question, that the provider can address the clinical needs?
Yeah, are the resources there? Do you collaborate in finding those resources? As I mentioned, it's always been kind of an uphill battle that way.
Yeah, so I think one of the things that we do a lot of is collaboration with our provider network, and specifically around cases that may come to us either through a clinical review, or they may come to us through utilization management or review, someone that's needing hospitalization or different areas like that. And I think that is an opportunity where we work closely with the provider on collaborating on what services are available, how best, can we meet someone's needs, and they often sometimes will reach out to us. We've definitely had providers say, hey, we've got this case, can we have a consultation? And so we're more than happy to be able to provide that. Because
so you feel that that's been something that has advanced over time? I mean, there was a time when finding that support for someone with a developmental disability was extremely difficult. So you feel there's been some progress that way? Are there more clinicians available to people?
So I don't know if, and I may not have as much history as previous, but since I have been, in my position, I've been with OCHN about 5 years. I think I've seen them be able to certainly find a way to make sure they're meeting needs, and I think there are definitely still challenges, but I think the providers do, a great job of trying to address those, and certainly then that's where if we're involved as the clinical team, how can we assist them with that also?
Okay, so it might still be a kind of a challenging support in the
There's
long run.
there can
So,
certainly,
Steph, I can weigh in
yeah,
too,
sure.
with a little bit of history too. So when I first started at OCHN about 10 years ago, I think I was one of about 4 clinical positions that we had in the entire organization. So now you see we have an entire team dedicated to clinical practice and providing clinical supports to our entire provider network. And then we have grown a lot just in terms of our clinical capacity. So not only do the clinical analysts get cross-trained, but we have people who are very knowledgeable and have extensive, we're talking like 10 years plus experience of actually working directly with people with developmental disabilities, with autism. So we really kind of upped our game, so to speak, over the last 10 years or so to make sure that the folks that we were hiring had a lot of background and direct experience actually providing the services. And then the number of people we have on staff with clinical backgrounds that are able to provide that level of support have easily quadrupled since that time as well. So I think we've made really huge leaps and gains in that area.
That's very encouraging, but I suspect we have a way to go yet. I think that trying to find the proper support for people with developmental disabilities, especially if there's an intellectual challenge, could still be a barrier? Or am I looking on the dark side?
Well, there's always room for improvement, no matter how much we think we grow.
Okay, well, it's something we're keeping our eye on.
Always. Yep.
Yeah.
Oh, that's the good news. That's all I
Yeah.
needed to hear. Thanks so much.
Thanks, Nicole.
Stephanie and Nicole, this is Pat again. But you said a majority of your contacts day to day are with core providers, right?
Yes.
But you have a number of clinicians. So how does that ultimately go down to direct providers, then ultimately to the person who needs the service?
Yeah, so I think looking at, like if I look at specifically the utilization management team. So that's a team and review. I mean, combined together, that's a team of 12 analysts who are clinicians. And they are really looking at those requests for service or supports for the individual. And so they're looking at that, they're communicating with that provider, getting that clinical rationale, like, hey, we see this, can you give us more information on that? So really doing that coordination piece there. Someone as they're discharging in the community, coordinating with the hospitals and the provider, like, are we set up? Do they have all the supports in place and a strong discharge plan? And so I think then we really see that trickling down to that person who is receiving those services, that they're receiving the services that they need to make sure that they can be successful and they can meet their goals. So that would be one example of how I see our work with those provider networks really impacting the people that we serve.
So you're really more like behind the scenes.
It's a lot of behind the scenes work, and important work as far as looking at those services and making sure that people are able to get what they need when they need it and be able to reach their goals and be active in the community is really our goal.
So if someone was not receiving the services they felt they required through their ultimately down through the system there, through the core provider to the direct provider to the actual clinician's help, who do they call?
A lot of times if someone is feeling they're not getting the services or supports they need, they may reach out to the customer service team. So if that's the case, Mike will direct whatever he thinks may be some sort of clinical involvement. He will direct that to me and we'll take a look at that and get involved if we need to that way. Sometimes we become involved through the due process coordinator. So someone may request a local appeal because a service or support was denied. And so the clinical team may get involved that way as well. So there's a couple of different avenues that someone could take.
Okay. Does anyone else have any questions for Stephanie or comments?
This is Malkaya. I just want to say I'm amazed at how much that department has grown. I've been on the board since 2007, and when you showed that chart, it was mind blowing. So I appreciate the work that your department is doing, and it was a very good presentation. Thank you, Stephanie.
Thank you.
Does anyone else have any questions or comments? Okay, it looks like we're good. Thank you, Stephanie. Great job.
Thank you.
We'll go on now to the reopening plans for the board meetings with Diana.
All right, so this is a follow-up to the board's request from last June to make sure as we look at how to resume and when to resume board meetings, that there is input from the board on configuration and recommendations by staff. So as we have made all of our decisions over the past few months, everything that we have done has been looking at guidance from the CDC, executive orders, MDHHS, and the Oakland County Health Department. It's been really important for us that we are trying to make things that are, in the best interest of people that we serve and understanding what happens with COVID. As we know, it has been very fluid, and what was relevant even a few weeks ago may not be relevant anymore. So we're always trying to make sure that we are staying on top of what is happening with COVID in general, meaning, what's happening with it being airborne, what is happening with it being on surfaces, because all of that impacts the people that are in our building. And as of right now, it's just a few staff, but it would also be pertinent if we were to reopen the building or to resume board meetings. We continue to look at what is happening across the country. As we know, as other states have been reopening, what we have seen are in some places very large increases of numbers. And we have also seen even increases in Michigan in the number of cases. And finally, as we put this together in our recommendations, we made sure that we touch base with our legal representation on developing the options to make sure that we continue to be in compliance with the Open Meeting Act. Next slide, please. So how are we able to have virtual meetings? The actual Open Meetings Act does not allow for us to be able to have virtual meetings. They require in-person meetings where the public can attend. When Governor Whitmer put us in a state of emergency, she was able to issue an executive order that allows for us to be able to have virtual meetings. And she put that in place because obviously we want to be mindful of how many people that we have in a room, especially when it comes to being indoors. If she does not extend the emergency order, she cannot extend the executive order that will allow us to be able to continue virtual meetings. We are expecting for her to extend both of those. However, there is no guarantee. As we know that the courts are getting involved with her executive powers, and she also may choose to extend the emergency order, but she could choose not to extend the virtual meeting executive order. So what we do know is that regardless of whether we decide to stay on virtual meetings for now, or if we decide to resume in-person meetings, we're going to need to make sure that we have that plan for resuming in-person meetings. Last thing that I want to make sure that I note is without her being able to issue an executive order for virtual meetings, the only way for government organizations who have to abide by the Opens Meeting Act is a legislative change, is the only thing that can make it possible to be able to have virtual meetings. So one of the things that we did as we came up with this, I'm actually going to go out of order for the numbers, is that we are recommending that if we do resume and when we do resume in-person meetings, that we continue the use of using Teams to stream our meetings. What we have found is that we have been able to have engagement from the public and being able to make public comment. But we also want to be able to do is preserve, especially while COVID is still impacting our community, for people to be able to join virtually to either give presentations or to be able to make public comment if maybe they're sick or at high risk or just don't feel comfortable coming into the building for a meeting. That is a board decision. And when I did talk to our lawyer, that is something that we would want to put into our bylaws and whatever the long-term plan is. So, but the next couple of slides are going to be is a walkthrough of the board setup. And all of these make sure that they allow for physical distancing. So the first setup that you see, because we cannot maintain the current board table setup because we cannot be physically distanced. So with option 1, as you can see, board members would be situated sitting around the room. And then we would have staff sitting to the side, which we'll have a picture of, and then 2 presenters. A mask will be worn per OCHN reopening policies, and we will have seating for 37 people in the public. Next slide, please. This just shows with the setup that you would have the CEO, the COO, and Sheila sitting to the side of the room. And then the picture on your right is of the presenter tables. As you can see, we pulled all of the tables out of the room, and we have individual chairs set up that have the perimeter of 6 feet all around them. The other option that we have, which is similar to what you may see at the dais for the legislature, and we also see it at the Board of Commissioners, is a multi-row setup. So you would have a row of board members in the back and a row of board members in the front. Then we have those 2 presentation tables. Regardless of which setup we use, we are going to have the public seating of 37 people. So once again, this just shows with option 2 where the CEO, COO, and Sheila would be sitting. So one of the things that we would be doing, and we actually actively have been working on, is because in the anticipation of continuing to use Teams, is we've been looking at the cameras in the room. The cameras were set up for a different purpose. So those will now be moved to a more central location so that all of the tables are captured, whether you're looking at option 1 or option 2. And then, as I said, we are recommending that all meetings continue to be streamed or presented via Teams instead of Pearl, which is the old streaming tool that we used to use. Option 3 that you have as a board is to continue existing virtual meeting platform using Teams, so everybody would be attending virtually until the emergency order and executive order are no longer available to us to be able to meet virtually. Other things that we are going to do to keep people safe, and this is what we do for our staff, is whenever our staff or community members come into the building, they do a health screening. This does two things. It helps us with contact tracing, but it also helps us keep people who have symptoms out of the building. So what we would be asking is for board members and community members to complete this form and assessment before you come in, and then we would check it off. If someone did not have the time or maybe the internet tools or whatever it may be to do this, we would have paper copies, and we have a thermometer that we would be able to use for them to be able to take their temp. Once again, all members of the public would be required to wear a mask. So with that, I am happy to answer any questions.
Pat, this is Jonathan.
Yep.
Okay, Diana, it's Jonathan. I know one of the things that a few of us have asked is, once we've seen this plan, now that we've seen it, if we would be able to provide some thought and then some input into it as well.
Absolutely.
Since it's our board meeting that we would be dealing with. I also know that the game plan, at least at this point, has been of opening the building has been postponed. And I don't think we have a definite date of until when.
So I'm sorry.
Because you mentioned that earlier.
Yep.
Today.
The current date is October 1, and then we will adjust that if necessary once Dana comes on board. Right.
So the other thing I was thinking about is right now we are meeting virtually. Most of us have cameras that work. But I wondered if there might be smaller tables that we could get for the board. So we'd each have our own smaller table, a laptop with a camera, so that, and we still have our microphones, so that theoretically we could be there in the building when it opens. We'd be at our own individual tables. We would still be able to stream. You wouldn't have to move the cameras because each of our desktops would have a camera. And we could still fulfill the in-person when we'll need to. And so that's just an idea that I'm throwing around, only because I'm on cameras all day with my work one. And it's just a matter of getting us all into the same room again. But those tables are really wide.
Mm-hmm.
And
well, and those tables, actually, Christine, I think the tables are 6 feet. Christine.
Yeah, so if we had 4-foot or 3-foot tables, we could each be at our own. We could maintain that 6-foot wide distance between each one, and still get us in the room.
Yeah. So
I was trying to unmute. So we actually, Jonathan, measured when we set the room up with facilities. We measured from seat to seat. The tables are just under 6 feet. I think they're 5. So when we set up that formation, we did measure based on where the chair would be from that point placement of the center of the table to the next placement of the center table. So they are spaced appropriately.
Okay, that's fine. Like I said, I'm just trying to get, first look at the plan. I know that the 2-row one, I know it at the county commissioners area. Yes, they're in multiple rows. They have like 6 rows, 7 rows, but that spacing takes up a lot of space in their building. I can't even imagine if there would be anything left in ours. So, and if we were wired, we could also have people in the atrium, in addition to did you say 37 people in the room?
Yep. So what we would actually do for overflow is that we have 2 other rooms. I don't know if you guys have been in them. They are Huron. I think you guys have been for interviews. They are Huron in Superior, and we could use those for overflow. That was our thought because all the technology is in there.
Right. So just some other things. I mean, it is more technology, and it's I don't know if those are Chromebooks with cameras or whatever they are, but it might be a way to keep the to get us there in person when we're allowed to, and still allow the facilitation of electronics. So, just
Okay.
a thought.
Thank you.
Appreciate all your work you put into this, and I know it's not easy.
No problem.
We have a question from Adam.
Diana, did I see that legal is suggesting that we meet virtually as long as it's possible per the executive order and any legislation signed by the governor?
Yep. And I completely forgot to say that, even though it was on a slide, Adam. So thanks for mentioning that. That is correct. It is not he was very clear. This isn't a legal opinion, but what he said is as long as the board can meet virtually, that his thought is to continue to do so because the visibility. So for example, Adam, when you are speaking on a virtual meeting, it's very clear that you're speaking, right? Because your name lights up, and then if you have your video on, it's going to show at the bottom and we can see you speaking. And that was one of the things that the lawyer made very clear, is that at all times, the public needs to know who is speaking.
Okay. Thank you.
You're welcome.
Judy, you have a question?
I do, and this time I got the microphone right too. I'm making progress. Diana, with the one setup, you had 2 rows of tables, right?
Mm-hmm.
And are they both rows facing forward? So would the second row be looking at the back of the people in the first row?
That is correct.
Okay,
it's putting it
a little challenging for discussion.
Right. Yep, which is why we wanted to give you a couple of options. And then of course, if you guys have any other options, this room is tricky, and obviously trying to get 6 feet between people, is a little,
sure.
It's a little different.
I completely understand the challenge, but somehow or another, talking to the back of somebody's head doesn't exactly improve the situation in terms of virtual versus in person. It seems like that might still be a barrier to spontaneous conversation. I just wanted to be sure that I understood properly. Thank you.
You did. You're welcome.
Malkaya, you have a question?
Yes, I guess I'm just wondering, Diana, out of the 2 options that you've shown us, which one do you favor personally as being the safest and easiest way to facilitate a meeting?
Yeah. They're both set up with safety in mind. And so as board members, you can choose, either one of those. And we are very confident that everybody is physically distanced. And that is really what's important to us, especially as we are seeing the numbers go up in Michigan. And we hope that those continue to or start to stabilize, but making sure that we have those 6 feet. So I don't have a preference. I don't think we have a preference as staff. We wanted to give you those, clearly the one where it's around the room, you're going to be able to see each other, and you're going to be able to have better dialogue. The other one where you are lined up in more of like a kind of like a dais and stadium,
right?
That gets everybody a little bit more condensed. So I think it's really just what your preference is as the board.
Well, if you took Jonathan's suggestion to get us smaller tables, will we still be able to maintain the distancing but be a little closer? Because I like the idea of having the face-to-face, but looking at this picture, it seems like we're going to be yelling across the room at each other. It just seems
yeah.
Go ahead. Sorry.
That's okay. So even if you were to make smaller tables, back to what Christine was saying, is that the layout of the room and the spacing is going to be pretty much the same, because you're going from 6 feet to 6 feet. So smaller tables would just really allow us more space between tables, because they measure that out. Does that make sense?
So it wouldn't get us any closer safely with the smaller table.
Suzanne, can you go back to option one? I think if it would be more helpful if we could go hang out and sit on that for a second. Thank you so much. So as you see, these tables are actually almost right up next to each other.
Mm-hmm.
So we could bump them together probably a little bit more, but once again, you know, what Christine and Mark did was measure from, if you're sitting in the middle, you have to be from, you know, 6 feet from until the next person.
Okay.
So even if we were to do, let's say, a 4-foot table, you're just going to have more space between those tables.
There's no easy way to do this, obviously. Thank you. I appreciate you bringing it to us because we, you know, trying to visualize it. And then it's different for those who've actually been in the room and seen the setup as opposed to looking at these pictures. But it just I just have visions of us yelling, even though we wouldn't be because we have mics and stuff, but still having a dialogue in a room spaced out like that. I'm just not sure how that would work. But I know we got to do what we got to do. So thank you.
You're welcome. And we did do some testing of the room. We had, as you saw, someone from the IT team was actually sitting in one of the pictures. And Christine and myself and some other folks were doing some testing to make sure that you can hear clearly. One of the things that fortunately you can do is if the board does decide to return back to the building, is that you can hear very clearly on Teams and you can hear clearly in the room. One of the changes that we've actually already made in preparation, so once again, whether this is next month or several months from now, whenever you know that would happen, is that the mics will no longer turn on. You will have to push the button for them to speak because we were getting echoes and feedback. So we've started making adjustments in preparation.
Thank you.
You're welcome.
Adam, your hand is still up. Do you have another question?
I'm sorry, I do not know.
Okay. Does anyone else have any questions or comments?
Yeah, this is Steve. I have a comment. It's really difficult to make these decisions based on information that changes twice a day. But with the newest information on the small droplets from person to, I mean, the big droplets from person to person and the smaller droplets that linger in the air maybe for an hour, the 6 feet thing may just be a myth. And the small droplets that can linger for an hour are going to get sucked up into the HVAC system and recirculate like it does on an airplane in an airport. So all of our efforts may be based on unscientific things. They make, I think a lot of the decisions are political, whether they want us to wear a mask or not, not based on science. That's all.
Well, and that is the reason why our recommendation would be for the board to wear a mask even when you're sitting at a table, except for, you know, maybe when you're speaking, because sometimes that cannot be clear. But though all you see, Andrew had a mask on and we could hear him. But you're right, Steve, it is really hard because what we're seeing is on a regular basis, the information is changing. It's a moving target.
Does anyone else have questions or comments regarding the opening?
So really as staff, what we are looking for is, Jonathan did give some feedback, and if anybody else has any feedback. So are you guys looking to make a decision today? Do we want to come back next month and discuss it more? So we would just like some direction on how to proceed.
Let's let Hadass. Hadass is raising her hand.
Can you hear me?
Yes.
Oh, it wasn't clear that you could hear me. Okay, great. I I mean, it doesn't matter to me if we make the decision now or later. I think you've done a really great job. We're so fortunate that we have that large room, considering if we're going to be, using the current 6 feet apart. I think option 1 is a very good idea, just because we'll be able to see each other. And it sounds like you've, checked it out, and we'll be able to hear each other. But I just wanted to thank you so much, because it is a challenge.
Thanks, Hadass.
Jonathan?
I would think at this point that with the building closed, with the delay of the opening, that we're probably in no real rush, unless we hit that point where the executive order is ceased to be in play, or that legislatively they extend the Virtual Open Meetings Act, if you will. So I would say let's keep investigating all other alternatives. I am not a fan of the 2-row. If I didn't say it before, I certainly am going to say that now. And I'm hoping that there's some way that we can do a hybrid of virtual and in person, because I'm not ready to be a guinea pig with the vaccine yet either. Thank you.
Okay. Does anyone else have any comments or questions?
This is Malkai. I kind of agree with, well, not kind of, I agree with Jonathan. If there's no pressing need, personally, I don't want to rush in, because you only get one opportunity to do it right. Because if you get sick and God forbid something happen, that's it. So I'd rather err on the side of caution and be deliberate and not rush unless something changes legislatively.
Yeah, I think that sounds like the message here is that we don't have to make that decision tonight, but some great work. So we got some choices just to begin with here, and let's see what happens with, from the governor's perspective on opening up facilities around the state.
Yeah, and from our perspective as leadership and from the technology team, facilities team, and everyone involved in this, we will make sure that we are ready when that time comes. If we no longer have the option. The other thing that we did do is reach out to Capital Services, our legislative consultant, and we just asked the question, are you hearing anything about permanent changes to the OMA being made? And they said that there are certain groups, I think one of them, the Municipal League of Cities, is going to be putting together or proposing that they change OMA to be able to accommodate virtual meetings long term. So that may end up changing. I don't know if it will change right away, but we may see some movement on that side as well.
Okay. Anybody else? Okay, I think that's it, Diana. Thanks a lot. Great work.
All right. Thanks, everyone.
All right. Now we'll move on to other business, and it's me, me and Anya. Kind of go over just an overview of the budget planning and how the money flows. We had a discussion about it at our last meeting, if you recall. And Anya and I worked a little bit together on putting together just some overall structural flow charts, if you will. It's just in Word, I believe, but just a couple charts just to kind of share with the board of how we're thinking of setting this up. And so the board has a very good understanding of the components of the budget and how the money comes into our organization and how it's spent within OCHN. I think that's something that it's important as a board that we are very transparent about. And so the public knows how we spend the money that we receive and to take care of the people that we service. So with that, I don't know if you have anything else, Anya, or is that okay?
Good by me.
Okay. Okay. Why don't we go to the next chart? Whoa, where did that chart come from? I'm having a hard time. You may have to explain this chart, Anya. I didn't expect that chart.
That's just a graphic.
Yeah.
We can move to the next one. There you go.
There we go. Okay, good. Okay, so if we look at the money that we manage, OCHN manages, the lion's share, 90% of it, almost 89.5%, is Medicaid money. That comes from the state. And then it breaks down into some other components. As you can see there's a state amount of money that we receive from the state. And then there's the substance, the SUD money. And then there is county money, and there is other, which a lot of that's grants. So our thought was to start looking at it from this perspective and take it piece by piece and walk the board through how the money comes in, what we're allowed to spend it on, and what we do spend it on, and any other information that's pertinent to the board to know as we're going through the budget process. You go to the next one there, Christine or whoever. So if that's the receipt of the money, it from the Medicaid perspective, again, a majority of it will go to services. But if you look at the way we expend our money, almost 94% goes to programs and others. So basically, that's all the caregiving services, all the programs that we're responsible for, and so forth, which we can go into the detail during our discussions at the board level over the next couple of months. Only 6% of it is for administration. And from my experience, that's quite a low percentage, which is good. And then if you look at the money itself, we had $339 million in this, and the change in net assets would be $4.3 million. Is there another chart there, Christine? Or is that it? Yes, here it comes. So the funding, service, and delivery paths. So probably starting from the bottom of this chart, the green box, if we take from MDHHS and Oakland County, the money comes up to OCHN. The Medicaid money will come up there. OCHN then it goes to either core providers or direct service providers for the people we service, and then ultimately to the people that we serve. Is there another one? So before we get into open for discussion, I just wanted to make another comment here. So the idea that we thought about doing was at our next, probably our CLW meeting, we spend time on Medicaid, since that's the big dog. That's almost 90% of the revenues that come in. And we take some time and we say, okay, here's the revenue money, how it comes in, what impacts it, such that, you hear terms like capitation, which I didn't know what that was before I got on the board, but now I do. It's the amount of people receiving Medicaid in Oakland County. If it goes up, we get more money. If it goes down, we get less money. And there's other things that impact it, like the rates that are used from the actuary who works on our behalf, and they work on the same rates, just so everyone knows, the same rates for all PIHPs in the state. So once a rate is set, there's components of the rate that impact how much we would get paid per person and how much the multiplier would work to give us Medicaid money. And from what I understand so far, and I've talked to Anya about and looked at the information, which we'll share if this is a good way to do it with everyone, is by getting the actuary to break it down in the lower elements of how they calculate the money has actually been helpful to us, because the expenses that we incur as a county tend to be higher in many regards because of the services that we're able to offer and what they cost. And so it's helped us in our finances this year, going from, at the beginning of the year, about a $9 million deficit, and we'll see soon where we stand on July. But Anya says we're getting closer to break even, still within a few $1 million away from it, but we're moving in the right direction. So if it sounds good to everybody, we would break it down by component, like Medicaid, state, like that first chart had showed. And then within the components, say, here's how much money we anticipate to get and in the budget, and here's how we would look at spending it piece by piece. And people could have opportunities to ask all the questions they want to understand it. So make sure there's nothing, misunderstood. Rena, you have a question.
In that first graphic, when you were talking about where the money is coming from, you said, the big chunk was from Medicaid, which came from the state, but then there's also that smaller percentage that was just state funding. Can you just tell me a little bit about the differences? Like what is categorized as state?
Why don't you answer that, Anya, if you would, please?
Okay. So when we talk about state money in particular, there's two different ways we get, several different ways we get state money. Primarily it's Medicaid. So it's Medicaid funding. That's partially funded by the state general fund and partially matched by the feds with federal dollars. And so that comes to us all as Medicaid. We also get what's called Healthy Michigan, just essentially the same thing, other than the match percentages are slightly different. So the match percent is much higher for what the feds kick in. And then from a county perspective, it's local money from the county that's collected through taxes. Does that answer your question?
It does, yes. And when you said Healthy Michigan, that I remembered that from the last conversation we had about the finances. Thank you.
Yep.
Are there any other questions, or does this sound like a reasonable way to go through this so everybody understands what's in the budget? Shia?
Yes, and the graphic, I think the previous graphic, it shows that the money is pushed out through the core providers, but there is also arrow pointing directly to the people. What services are those, or what does that cover?
Anya, feel it's you again.
Yep. So the idea behind this chart, this chart has been around for a long time, and the idea behind this chart was to offer a streamlined option from how things were done previously when we contracted for all services before they actually went to people. So part of what we have done is to contract directly with some direct service providers, as opposed to going from a core provider to then a direct service provider and then to people. So what you're seeing is just an intention to show a graphic of reducing administrative layers.
Okay, so, but it's still not clear to me that this OCHN to people, how is that? I mean, can you give me an example of that?
Well, so ultimately all of the arrows are pointing to people, services for
right
people.
Yes.
So that's kind of the intent here, is that the ultimate goal is to get services for people, however that's done, whether that's through a direct service provider, a core provider, or in some cases, we don't pay people that receive services directly. So this isn't really intended to show about paying. This is intended to show that all services go towards people, if that makes sense.
I see. Okay, thank you.
Any other questions? Does this work for people, or is it, would you like something, a different approach?
Pat, this is Malkia. I guess I'm not understanding what it is you're trying to accomplish with this. I'm just a little confused because I thought we got this information on a monthly basis with the reports. So I'm not, you're asking for input. I'm not sure what you're looking for from us.
Well, what the idea was, Malkaya, is to take a deeper dive into sections of the budget so you didn't get a whole, remember last time Anya went through the whole top to bottom components of the budget. And this was to say, let's explore it in components, like in this case, Medicaid. Let's take Medicaid and say, okay, the Medicaid comes in this way. This is what impacts the amount of money we receive from Medicaid. Here's what OCHN by Medicaid rules are able to pay for, and here's how we pay. And then the key is, here's how we spend it within those rules. And it goes in, if you recall, I know the spreadsheet, but it's way out to the right. The spreadsheet, all the different areas where the money is being spent from OCHN.
Okay.
So the idea was not just to dump an entire budget on people's laps the first, once in a while. It's more into
with us
to the component. And when I say components, I say Medicaid, state money. But someone had a conversation, I think. Who's ever had talking to put on
Pat,
mute?
I'm just going to go ahead and mute all. So then just go ahead and unmute yourself in just a second.
Okay.
Nicole, I muted.
Okay, Pat, you should be able to go ahead and unmute yourself.
Yeah, I'm sorry. So, the idea was importantly is how OCHN spends the money we receive and where it comes from, and what are the rules on how we can spend the money.
So are you looking at next year's budget, just taking next year's budget and breaking it down that way?
Yes. Yes.
Okay, because that wasn't clear to me.
Yeah, I'm sorry.
It didn't show,
yeah,
total revenue. Is this new money, old money? I didn't, that's why I was a little confused. But
yeah.
I guess I understand it better now.
Yeah, it was the money from our last meeting that Anya had showed with our first amendment to this year's budget.
Okay, thank you.
I should have said that. Does anyone else have any thoughts or comments? So if it's good with people, we will start with Medicaid at this next CLW meeting, and Anya will do most of the talking there, going through all the components of not components, but all the areas where we spend the Medicaid money, how it is spent, and what impacts it. Is that okay with everyone?
I just have one other question. Since we're talking about next year's budget, are we going to be able to tie it to the annual plan as well?
It should.
Okay, thank you.
Yeah.
So just to add to that, we do our best to add funding amounts in the annual plan. It's not quite as clear cut as just being able to say something very specific, depending on the annual plan goal. So something like advocacy per se, we may not be able to put a specific dollar amount on it, but we do try to associate amounts with the annual plan goals.
Thank you. But since we're having this conversation about where the money goes, it would be nice to be able to say this satisfies this part of the annual plan when we're having a discussion. That's why I brought it up.
And we should
not trying to put any extra pressure on you.
I think that would be appropriate. Pretty much could do that for many of these things, I believe. Jonathan, you have a question?
I do, or a comment on it. I know we've just raised the annual plan and trying to tie off, actions and dollars to each other. But I also know we have the strategic plan coming up that, if my memory serves me, is supposed to be done this year too for the next 3 years. But I'm hoping that all of that can get postponed until we can, maybe not the budget for next year, but the annual plan and the strategic until we do get our CEO on board. So that the CEO can provide some, hands-on vision and, leadership to where we're going to go for the next 3 years versus walking into something that they may have to live with for 3 years. So I'm also hoping that I know the budget has to go down to the department and down to the line item, and I know it makes sense to be able to allocate down to those dollars and cents, if you will. But I've always had this thing about, our strategic plan and our annual plans have like 100 or 150 different line items to it in terms of goals and objectives, and then tasks and activities even more so. And I'm hoping we can get to a simpler set of goals and objectives that we can say this is what Ocean's trying to do this year or in the next few years in terms of evolving and innovation as an enterprise. And then maybe specifically, here's a few that are specific to each of the different populations that we serve. So it becomes a little bit more focused and a little bit more collective, if you will, in terms of being able to move the ball down the field, not in inches across a whole bunch of different topics, but maybe in terms of yards or first downs, now that we're getting close to football season. So, and I'll just go to mute after that.
Thanks, Jonathan. And I think that was some good points. I see where Nicole put a comment, said FY21 will be a strategic planning year to plan for FY22 through 24, so we have some time on the strategic plan. And Bajaya, you have your hand up.
Yes, thank you. I think I agree with Malkaya that it will be important to kind of correlate the budget for the next year with the annual plan. We don't have to go into every detailed piece of the annual plan, but just in kind of in broad terms as to what part of the annual plan a particular piece of the budget satisfies. I think that's a great idea. Thank you.
Does anyone else have any comments or thoughts? Okay, so I'll work with Anya on getting things put together for the next CLW, we'll take a crack at going through Medicaid and see how it works out. We can change on the fly if need to. So at this time, I turn to Sheila. Is there any other public comment, or is it Emily? I can't recall.
Hi, this is Emily. Yep. There is no other public comment at this time.
Okay. And I don't see anything on the chat line or nothing. So I guess now we'll turn to board member comments. So if we can go around to the board, Sheila, if you can call off everybody and see.
Sure. Ms. Newman?
Thank you, Sheila. It was a very, very good meeting. A lot of information, a lot of food for thought, especially with the setup on the room. I especially appreciate the staff with all of the time and work that they put into preparing for these presentations and preparing to bring us the information, because I know you're trying to satisfy 12 different people with 12 different needs, and I know it's not easy. But I do recognize that you are making a concerted effort to get us the information that we're asking for, and I really appreciate that. So thank you, and everybody be safe and be well. And hopefully everybody will be a part of the Minority Mental Health Month event tomorrow. I don't know if it's too late to register or not. Christine can speak on that. But I'd like to see board members attend if it's at all possible, especially since the Lieutenant Governor will be in attendance. Thank you and good night.
It is not too late to register, Malkaya. We are well over 100 people attending statewide.
Yay!
Dr. Todd?
I thought the presentations were very comprehensive and really good for the new board members. And I wanted to say something that I didn't say before. We used to also get a source of funding from the state called general funds, and it used to be around between 40 and 50 million dollars. And last time I looked, it was down to 12 million, and a great portion of that is going to cover spend down. So we really don't have to deal with it since it's disappearing quickly. And everybody be safe.
Thanks, Steve.
I don't know if Adam's still on. I know he had to log off, so I just wanted to make sure. Is Adam, are you still on?
It looks like he left, Sheila.
Okay. And I know Dr. Guadalupe is gone. Mr. Landsman?
Thank you. I want to thank everyone who presented today. It was very informative. And I want to point out something that I've raised in the past. And even when we had folks like Sid and Al and others on the board, which is at one point or another in the past, we had, and today was the first time I'd seen it in a while with Pat doing it. We actually had someone from the board actually presenting out to the board and to the public on a topic in conjunction with a staffer. And I've always thought that that made a lot of sense to be able to take the message to the people, if you will. If we're looking at a topic and we report out, that perhaps other board members, that we take a shot at reporting out rather than just putting it on the backs and the shoulders of our staff. So Pat, good job. Thank you.
Thanks, John.
Dr. Hahn?
Thank you once again. A very great meeting and great presentations. I especially want to thank the staff for their hard work. I know how difficult it is working remotely when you have to take care of the needs of your family, especially children who are kind of getting a little antsy these days. So I wanted to thank everyone on the staff for the work that they are doing during this time. Thank you.
Ms. Bernard?
Hadas, you might be on mute.
I'll go to Mr. Torres.
Hear me? Okay.
Yep.
Okay, good. Yeah, I like the idea of discussing budget more in depth, understanding the different funding streams. I did have an opportunity to sit with Anya after coming back to the board, but then I was previously on the board from 2011 to 2013. So it gave me a lot of insight, obviously, into the funding process and the state, federal, and county dollars. But I think it's a really good idea. So I'm glad that we're talking about having more comprehensive look and discussion about that. I like the idea too that Jonathan brought up about board members bringing or working collaboratively with somebody from administration on a topic that they would bring before the board or board meeting or committee to present. I think we all bring something to the table here. We all got a point for some reason with having to do whether it's substance use, mental health, or developmental, all of it. So there's so many different things that we have talents, but we know each other a little. It's definitely a lot harder. You even get to know some of the new board members and their specialties in the era of COVID because we haven't had an in-person meeting since March. So I would love that. My specialty is criminal justice and mental health, and that's something that I'm very passionate about. So I would enjoy that, and I really enjoyed the presentation from Christine on the communications. I think is very important, especially in today's day and age with everything just being done through electronically and social media and other outlets. Thank you.
Mr. Lindermeer?
No comments.
Ms. Namie Dyer.
Yeah, I just want to say I'm continuously impressed with the amount of information shared and presented during these meetings. And I really appreciate all the efforts being made to come up with multiple options for returning to in-person meetings when it is safe to do so. I'm really looking forward to it. I think since I've been appointed, I've only been able to be in person once. So I am looking forward to being able to work with all of you in a closer capacity when it is safe to do so. Also definitely looking forward to the next COW meeting and delving deeper into the finance. I'm really looking forward to that and learning a lot more, especially as a new board member. I really want to make sure that I'm doing my part in all of that. And just especially with numbers on the rise again, everybody please be safe. Thank you.
Dr. Todd.
I already made a comment.
Oh, I didn't have you checked off. Sorry about that. Miss Bernard. Let me come back here. I know I called her already. I'm not sure if she logged off already, so.
But she's on the meeting.
Miss Summers.
Thank you, Sheila. I appreciated the information shared in the overviews on the communications and the clinical services. Always interesting. I always learn more. And I think part of the reason I continue to learn more is because we keep our approaches so fresh and so current, so that what I knew 2 years ago is not the same. And I appreciate having those updates and being a little bit more aware of everybody's effort. I know everyone works hard. The other thing is that regarding returning to meetings, I miss our in-person meetings a great deal. We gain so much more by being together. So at least if nothing else, when the time comes to get together, I hope we can at least see each other's faces. And I would prefer not to have the 2-row system and look at somebody's their back, or have them look at mine, which is probably worse. And also, Pat, thanks for taking on the task of trying to get us the smaller bites on the budget. I really appreciate your effort that way. I'm with you. I hope everybody stays safe. It's a little bit uncertain again, and I think it's unsettling to all of us, but stay safe and be well. Thank you.
Mr. Kemp.
Sheila Hadass said she's here on the conversation, so I don't know, Hadass, if you can unmute or whatever. While I'm reading what she said. Can anyone else see what I see?
Yeah.
Yeah, we can just read her comment. She said,
Yeah.
Thank you, Pat. I really liked your idea regarding the deep dive into the revenue. I also want to thank everyone for their, mine cuts off after that.
Presentations, particularly Stephanie and Christine. I hope we can increase branding of OCHN.
Okay.
It's good.
So then Mr. Kemp, last one.
I appreciate everybody's input tonight. I think that's always very helpful, and it would be great if we all could get together in one room again, but I don't know when that will happen, so we'll deal with what we have to deal with. And I appreciate what Christina and Stephanie did tonight with their reviews. It was very strong learning for me. And Christine, I will be getting back to you on some ideas I have about pro bono advertising. So we don't have to buy it. There may be some ways to get around that. So we'll see. Legally, of course. But there's some, we used to do it. So I think there's ways of doing it. And that's all I have. Is that everyone, Sheila?
Yep, that was everyone.
Okay, so if there's no other comments or thoughts, the meeting's adjourned. Have a good night.
Good night, everybody.
See you tomorrow, Markaya.
Yes, Bill. I'm almost done with my PowerPoint.
We're waiting. You can be patient. Thank you.
Thank you.